Hello, my name is Alfredo Quiñones-Hinojosa. I'm an associate professor of neurosurgery, oncology, cellular and molecular medicine, and neuroscience at Johns Hopkins University Medical School. I am delighted and honored to talk to you about brain tumors today. I will be talking to you about the history of brain tumors, types of brain tumors that one may encounter when dealing with this disease, the treatment mainly of the non-cancer brain tumors with a special focus on the cancer brain tumors, the possible etiology of some of these tumors, as well as the future research that my group, as well as other groups around the world, are conducting in this disease. Let me take you through the history of brain surgery. It turns out that it was not too long ago, a little bit over 100 years ago, brain surgery was the unexplored frontier. At Johns Hopkins University, a young surgeon by the name of Harvey Cushing was one of the pioneers of not only understanding the brain from the inside by doing brain surgery, but also developing new techniques to be able to do things that now, at present times, we take for granted. This was the image of one of his own illustrations that he did as he was coming out of the operating room. And as you can see, he was mapping all the way from the leg, the arm, the neck, the face, the head, the tongue, eye, speech, eye, hearing here at the bottom, and vision in this area. An incredible amount of work that it took for him to do this in 1903 at the Johns Hopkins Hospital. This was the beginning of brain surgery. By the 1930s, Dr. Penfield out of Canada, who was also a disciple of Harvey Cushing, was able to produce the so-called homunculus, which is what we now learn during our education. This is the overall mapping of the cortex of the brain. This is what allows us to sometimes find corridors and ways to go into the brain without hurting the normal function of the brain. It was thanks to these pioneers early on that we are now able to take some of the most challenging brain cancers and brain tumors that are known to humans. This is the picture of an extra-axial tumor. That means not from the brain. Some people may even call these tumors benign in nature. Why? Because they're not truly invading the brain. But I would dare someone, and I would challenge anybody, call this gigantic tumor benign. It doesn't matter if it doesn't penetrate the brain, but just the fact that this tumor is so large and is putting so much pressure in normal parts of the brain that makes their surgery challenging. Yet, we can still achieve cure in some of these tumors if they are the non-cancerous type. This is an illustration, as you can actually see right here, seen from the top of such a tumor. This is a so-called focal-tentorial meningioma, giant in nature. And as you can see, we have to take into account not only the anatomy of the tumor, which is seen right here, but also the anatomy of some of the blood vessels that are extremely crucial for us to preserve and not injure the patient. Some of these procedures are challenging. Some of them can go on for 20, 24 hours, multiple teams working together. Yet, some of these challenging tumors, if they are the non-cancerous type, they can still be cured with surgery, especially at centers that is specialized with a large volume of cases on the treatment of this disease. This is the postoperative scan of this particular patient that I did with some of my colleagues a number of years ago. And as you can see, we were able to successfully remove this gigantic tumor that it was in the back of the head of this patient that was having severe symptoms. I'd like to illustrate to you one particular case presentation. This is a young woman that I saw a couple of years ago. A 38-year-old, previously healthy woman presented to the emergency department with severe headaches. It was also experiencing diminished smell and taste over the course of the last year. Her personality, as you can see, was of a flat affect and decreased smell. So she was clearly having some symptoms from what it was found to be a very large brain tumor in the anterior cranial fossa. As soon as I saw those images at that time, I imagined that this was going to be a challenging procedure. I thought in my differential diagnosis that this lesion was going to be a tumor that did not come from the brain, the so-called extra-axial tumor. And at the top of my differential was a meningioma, based not only on the MRIs, which you can actually see in the axial cuts. These are cuts that are going like this through the brain. You can actually see the anterior cranial fossa. These are multiple different cuts. In this corner right here, you can actually have a little bit of the idea of the eye sockets. So we're cutting right above the eye sockets, and then we come below right here, and you can see all this white stuff. That's all the swelling in the brain. So this tumor is giant in nature, and is putting so much pressure on the brain that the brain is swollen. So I had the idea that this was going to be a non-cancerous tumor, but one that was going to be challenging to take out. So we took this patient to the operating room. We did an incision from ear to ear because the tumor was quite challenging. We pulled the skin forward, as you can actually see in this illustration right here. We took out the bone, that's the frontal bone, this portion of the bone, which is this right here. Then we took out the bone right above the eyes, this rim of bone right here, in order for us to be able to come straight down into this region, into the brain, without putting any retraction on the brain whatsoever. And this is a picture, an illustration, just like you're seeing me right here. The skin is pulled forward. We're coming right at the base of the skull in order to minimize the retraction of the brain. Ideally, you want to put no retraction of the brain whatsoever because you want to preserve as much function of the brain as possible. So this tumor was coming right here. My suspicion, once again, is that this was a not cancerous tumor that we could potentially achieve a cure on this patient. So we ended up taking the patient to the operating room, and you remember this gigantic tumor in the anterior cranial fossa, and it's completely gone and cured. We were able to achieve a cure on this patient. Years later, we have followed her, and her personality has come back to normal. Olfaction, unfortunately, was gone because all the olfactory nerves that were in this area were invaded by this tumor that was not cancerous in nature, but nonetheless, they were so thin and so damaged that there was no possible way to dissect them away. So we were able to achieve a cure on this tumor, and the final pathology ended up being a meningioma. Let me show you another tumor that is thought to be not cancerous in nature. This is what we call a pituitary giant adenoma. Pituitary adenomas are not thought to be cancerous because they don't invade the brain. But I would also dare anybody to tell me that this is not a dangerous tumor. You can see it's almost the size of a tennis ball that is grown right at the base of the skull up into the brain, and is putting a fair amount of pressure. Up here is the corpus callosum. You can actually see the vessels completely pushed upwards in this area. You can actually see right here on the bottom the brain completely pushed laterally like this, and very, very challenging tumor to take out. We have our institution at Johns Hopkins and other parts of the world, people have tried to do this surgery. Surgery for brain tumors that are not cancerous, much more minimally invasive. At our institution, we have devised ways to be able to take these tumors, sometimes, depending on the size, even through the eye. This is a picture of an eyebrow, and you can actually see the eye right here where we took the tumor, some tumors, through this approach right here. This is a view as we're going right through the brain, right here, moving the brain away, getting right under the skull, because the challenge is obviously to get right under the brain, get into that area, and extract these tumors. Another way of taking these tumors out is by doing it transphrenoidally. This is the picture of a young child. We have actually developed some of these techniques and perfected some of these techniques at our own institution, going through one nostril, as you can see right here, to be able to take this tumor out right here, using maneuvers in the operating room, sometimes using the own fat of the patient to be able to reconstruct the base of the brain, as you can see right here, and to be able to achieve a cure in these not cancerous tumors. So once again, we can achieve a cure in tumors that are not cancerous, not all the time, but the majority of the time, if we do the appropriate approach, the appropriate surgery, and if a multidisciplinary team is involved. Some of these tumors require a combination between a brain surgeon and an ENT surgeon or a plastic surgeon, depending on the approach. I always encourage my patients to not only seek a second opinion and go to major tertiary care centers that specialize and do a large volume of these procedures, because I think it's very important to have a good understanding of the anatomy and plenty of experience in doing these approaches. But what about those tumors that are considered to be cancerous? One type of tumor that is increasingly being more heard about in the media because of people like Senator Kennedy, that was afflicted by a glial tumor, also known as a glioblastoma. These are the so-called intraaxial tumors. We have, within the intraaxial tumors, we have the low-grade gliomas, we have the high-grade gliomas. Within the low-grade gliomas, we have the juvenile pilocytic astrocytomas, the so-called JPAs. We have the astrocytomas and the oligodendrogliomas. They're all in the family of cancers, alrighty? But the low grades tend to have a much better prognosis than the high grades. That is, those patients that have a low-grade glioma tend to survive much longer, versus those patients that have a high-grade glioma, the most devastating being the glioblastoma multiforme. Now, I tell you something. I believe the glioblastoma multiforme is the most devastating cancer that affects the most beautiful organ in the brain, in the body, which is the brain. One of the challenges that we face is that by the time that these tumors get diagnosed, specifically the glioblastoma multiforme, the GBM, most of the cells that we can take out with surgery are visible in MRIs, and sometimes they are visible in surgery. So we can achieve a very good resection of these tumors, what we can see. The problem is, as we look back in history, a lot of the cells that are malignant have already migrated away from the brain. And if you look at some of the studies that have been done, up until the contralateral side of the brain, one can actually find cells that have already migrated, and that's one of the reasons why we can't achieve a cure with brain surgery for this cancer. And this is an important distinction to make between those tumors that some people may call benign, like the meningiomas or the pituitary adenomas, versus these tumors that are considered to be malignant and invasive. This is true cancers. Cells have actually moved away from this region. This is a picture of the necessity that one has to be able to help patients and sometimes to achieve the best possible resection during surgery. This is a patient that had the tumor before and after and underwent a subtotal resection. This is a tumor that had a tumor before and after and had a near total resection. This is a tumor that had a patient that had a tumor before and after and achieved a gross total resection and a low-grade astrocytoma. Once again, it's still in the family of cancer, but this is the low-grade type. When we look at the overall survival of these patients, this is a Kaplan-Meier. In this axis, we have the percent survival. In this axis, we have the months. Then you have gross total resection, GTR, as seen right here. Then you have near total resection, NTR, and then you have subtotal resection, STR. So it's clear that the more tumor we can take out in our patients, the better those patients will do after surgery. And that is an important distinction to make. That's why these patients need to be seen, in my opinion, by people that have a fair amount of experience taking these tumors out. What about the perspective in the glioblastoma multiforme? I told you already, within the brain tumors, it's a spectrum. The low grades to the high grades. The low grades being tumors like the oligodendroglioma, the astrocytoma, juvenile pilocytic, or the low-grade astrocytoma, versus those tumors that are high grade, like the anaplastic astrocytoma, or the most devastating, the glioblastoma multiforme. In 1978, the median survival for these patients was about 10 months. That means many patients survive less than 10 months, and some patients survive more than 10 months. By the 1990s and the 2000s, most people began to do much more aggressive, not only resection, but to treat these patients with chemotherapy and radiation. And Roger Stupp in the New England Journal of Medicine published this paper. After gross and the best surgical resection that one can do, followed by radiation and chemotherapy, the median survival went from about 10 months to 14.6 months. Now, some of you guys may think that that's not a lot, but it's at about a 50% increment in survival of these patients. And this is something that one has to take into consideration if one day we are going to be able to make a difference. We can't give up in this disease, which is the so-called glioblastoma multiforme. This is an MRI of a patient that has a glioblastoma multiforme. What you see right here is what I can possibly take out in the operating room. Now, this is a tumor that is in the dominant hemisphere of this patient. This is an axial cut, and this is a coronal cut. Now, we have been able to confuse many people because we actually flip the images. In this case, this is the right side of the patient, even though it may look to you like the left side, and this is the left side of the patient. Once again, this is the right side of the patient, this is the left side of the patient. All right, there, the images are flipped. In this case, this patient has a tumor in the dominant hemisphere. And I will take you a little bit as to how we best do this surgery. Before the surgery, most of us use what is called a navigation system. And the best way that I can explain this is that we take an image of your brain before the surgery with very high definition magnetic resonance imaging, MRI, and we bring those images into the operating room, and we use something that is similar to a GPS that you use in your car. So that means that when we're pointing into your brain, we have a better idea as to where you or I are in reference to a pathology. I know where I am, and I use pointers, little pointers, to make sure that I am in parts of the brain where I'm going to be able to take these lesions out. And in this case, it may not be perfect, but it's one of the closest things that we have to be able to have a better idea of how we are going to navigate. It's not perfect because, as you can imagine, once you open the brain, things shift a little bit. So now you're dealing with shift of the brain and an image that was done before we had opened the brain. Nonetheless, this is a very good start to be able to navigate the brain and to achieve, ideally, a much better resection of these tumors. Now, what do these tumors look like? So I'm going to take you now into the operating room, and I'll show you this surgery. This is a young patient in which I am taking a tumor near the motor cortex. I have been able to map the arm in this area and the forearm, and this, as you can see, is the tumor that we're taking out. I am working inside of the tumor between a very large blood vessel, a vein that I am trying to preserve. And what I'm doing right here is using a small device that is called a bipolar and a suction right here, and I'm getting towards the edge of the tumor, and I am making sure that I am resecting as much tumor as possible without compromising the normal function of this patient. We are working on the right side of the brain in this case, so it's not the left side. Otherwise, sometimes we would have to do these patients awake if the tumor is near the eloquent parts of the brain. So we're working on the right side of the brain. I introduce a small piece of cotton ball to be able to just control the hemostasis, sometimes the blood. Sometimes I try not to use this device too much because it actually coagulates the small blood vessels. And right now I am getting right under the vein right here, and as you can see, there's still a little bit of tumor left right here. I'm towards the end of resecting this tumor. This tumor ended up being an intermediate grade tumor, and we gave the patient a gross total resection, and this surgery took place over 3 years ago, and the patient is done very, very well. So this is the resection. I have taken you into the operating room. This is the postoperative image of this patient that I show you after doing a gross total resection of this tumor. As you can imagine, these patients, if the surgery is properly done, if we map this brain well, we can achieve very good resection. These patients can do very well. This is an estimated Kaplan-Meier plot survival of patients with grade 3 astrocytoma. Remember, grade 1 through grade 4. Grade 1 and grade 2s being the low-grade gliomas, grade 3 and grade 4s being the high-grade gliomas, and the grade 4 being the glioblastoma multiforme. Here, you have gross total resection, near total resection, and subtotal resection. Gross total and near total are significantly different than the subtotal resection. This, as you can see, is the percent survival, and these are the months that the patient survived. So the more tumor you can take out, the better these patients will do. And that is a very, very important difference. Sometimes you can achieve very good resection if you not only understand the anatomy, but if you also use a state-of-the-art technology, mapping techniques, and other adjuncts, technical adjuncts that you can use in the operating room. This is the role that external resection has in survival after the resection of the malignant astrocytomas right here. This is being the grade 4 astrocytoma. And this is after a primary resection, and you can actually see gross total resection being the top curve. Then there is near total resection being the middle curve, and then there is subtotal resection being the lower curve in this case. This is the percent survival in this axis, and these are the months. So the more you can take out also in this grade 4, the so-called glioblastoma multiforme, the better those patients will do. It's not only important the first surgery, which is the primary resection, as you can actually see right here. This is the first surgery. But what if you have to go a second time? The second surgery, the so-called revision surgery, is also important. Gross total resection right here again, percent survival in this axis, months in this axis, and you can see that the more you can take out, the better these patients will do, the more they survive. So the extent of resection is important, not only the first time of surgery, but also the second time of surgery. But what happens if maximal surgical resection is the goal? Then what is the effect on survival for patients with malignant gliomas who acquire surgical-induced neurological deficits? It makes no sense if you can take everything out, but if you leave the patient completely devastated and hemiplegic, then it may actually work against you. And we have looked in our own work, and a lot of the data that I've shown you is based on our own work at Johns Hopkins, that this is actually true. This is the Kaplan-Meier, once again, the association of surgically acquired deficits and survival. This is after primary resection of a glioblastoma multiforme. In the black line right here, we have no new postoperative deficits. In the blue line, as you can see right here, we have new postoperative motor deficits. And in the red line, we have new postoperative language deficits right here. This is the percent survival, and these are the months. And as you can see, there's a significant difference. If you do a great surgery and you take everything you can, and after the MRI you look at it, you don't see anything that has contrast. But if you give the patient either a motor or a speech deficit, those patients will survive less, and their quality of life will be absolutely devastated. This is why doing a good surgical planning, be it at a major tertiary care center for the resection of these tumors, is, in my opinion, crucial. I'll take you now into the intraoperative setup. Not only did I show you what the surgery looks like, but let me take you in for you to see some of the pictures and some of the issues that we deal with in our planning of these surgeries. You can actually see this is the intraoperative setup for an awake craniotomy. This is the left side of the brain right here. The anesthesiologist is on this side right here, and we're all working together with a very large number of people in these very state-of-the-art surgical rooms. We have a stimulator right here to be able to stimulate the brain when we are doing the surgery. At the time of the surgery, sometimes these patients can be awake or they can be asleep. The tumor can be in the dominant hemisphere, that is the left side, or they can be in the motor sensory area. For those tumors, we have to do motor and sensory mapping. For patients that have a tumor in the left side of the brain, many times we have to actually do awake craniotomies. We go on and we actually put a small electrodes, not only the arms and legs, because sometimes all it takes is just a little twitch, and sometimes you just can't see it. But with these small electrodes that are recording EMGs, that is muscles that are twitching, we can actually detect very subtle abnormalities. We go on and stimulate. This is what is called intraoperative localization of not only motor, but we can also use this device, and this is the little electrode right here, which is no bigger than about 5 millimeters in distance. Between these two electrodes right here is about 5 millimeters. We use this to stimulate if we want to map the motor portions of the brain, or if we want to map the speech centers of the brain, we use such a stimulator. This is a picture of what it looks like right here. In this case, we were on, and in the operating room, we map the motor shoulder, the motor forearm, the motor hand right here, and in this case, the sensory hand and arm. And the lesion, roughly speaking, is all this area right here. And now notice how this tumor has displaced, opened up the space in this region where these cortical eloquent parts of the brain are found. So we have to be very careful. Some of the modern technology that we use has been published by other groups, in which we can actually use the so-called diffusion tensor imaging, subcortical white matter tracts. So we get a sense as to the relationship between a tumor and parts of the brain that are important for naming, parts of the brain that are important for movement of the mouth, part of the brains that are important for producing speech. And you can actually see such a picture sideways like this of a tumor that is surrounded by all these spinal tracts. So we have to pay close attention to this. I'll take you back into a surgery. This is just a few hours before the surgery, in which I mapped a brain in the operating room, in which I am looking at all the spinal tracts that carry a lot of information on the brain. And what I'm doing right now is mobilizing the brain and looking at it from different angles right here. I have recorded this. I'm looking from the back right here. I am using my mouse and moving the tumor. I want to get an idea where the tumor is in reference to all these cortical spinal tracts, all these tracts that send information. I'm looking at it from the bottom. I'm looking at it from the top. I'm looking at it from the side. Every single possible angle, because I am picturing in my brain in a three-dimensional way which way is going to be the way that is going to allow me to go in to the brain and minimize the injury to those eloquent white matter tracts that carry a lot of information from the brain down to the brainstem. So I'm actually doing this, and I spend sometimes hours sometimes days, studying these cases to make sure that in the operating room I maximize the likelihood of minimizing injury to these patients. As you can imagine, not only awake craniotomies are challenging for the patient as well as for the surgeon. Having a relationship with the patient, having a two-way conversation before the surgery will maximize the likelihood that during surgery, these surgeries will have a better result. We usually use the speech mapping, once again, for tumors that are in the left side of the brain. We can look at Broca's area, which is production of a speech, which is that little area right here in the front. We can look at understanding of the speech, which is also known as Wernicke's area, which is in the temporal portion of the brain. And then we can look at the connection pathways between these two regions, Broca's area, Wernicke's area, and the conduction pathways that connect Broca's to Wernicke's right here. So whenever we have a tumor in the left side of the brain that is in this vicinity, most of the time I do recommend an awake craniotomy. Unless there's a contraindication to awake craniotomy, sometimes I actually recommend that we do a functional MRI, which is also known as fMRI, to look at anomia, speech arrest, yellow motor, and we have, as well as other groups, done a correlation between the areas that the functional MRI gives you and the areas that we actually stimulate in the brain with the Ojamin stimulator during surgery. So these studies have been done, though these are reliable methods to get a sense as to whether or not we should do a patient asleep or awake. In general, my preference is when there is a tumor in the left side of the brain, which is in this case, remember, the image is flipped. This is the left side of the brain, this is the right side of the brain. So in this case, most of these patients, I do recommend an awake craniotomy. I get asked that question, when do you do an awake craniotomy? Most of the time is for speech. Sometimes some patients also get awake craniotomies for tumors that are near the motor and sensory area to be able to map those areas very well. And sometimes it becomes a surgeon's preference to do this. This is the picture of one of my own patients in which I did, all the way back when I was a resident, the mapping of several languages. We now know that patients can actually have languages arrested, both of them. In this case, Chinese and English. This is the age at which the patient acquired this language. And some of these patients can have sites with different languages, or in this case, both sites arrested both languages. So the variability is enormous. This is why many times you can't just do the patient's sleep, and you have to see, you can actually see the resection cavity right here. Look how close we are to the areas of the speech, just millimeters away. This is a picture from the operating room, and we have achieved a gross total resection of this tumor, and this is a paper that we published a number of years ago, and this is the overall results. As I was training, we were able to do some number of patients that were bilingual, in which we found several areas, as you can see, Chinese and English, English and Spanish, Punjabi and English, Turkey and English, as well as Spanish and English. So there's an incredible amount of variability, and this is why if the tumor is here or the tumor is here in this vicinity, I would recommend that a patient most likely have an awake craniotomy. This is a reconstruction of an MRI from the operating room. What about the treatment? Well, it turns out, this is a paper from Roger Stoop, New England Journal of Medicine, I alluded to in my prior talk. Radiotherapy plus concomitant use of temozolomide for glioblastoma multiforme. That means at the same time. Most patients have it for 6 weeks. They have the chemotherapy every day. They have the radiation therapy 5 days a week. We start 2 to 4 weeks after surgery, and they get radiation plus temozolomide at the same time. This is temozolomide is an oral medication, and you can actually see if we do that with a good gross total resection of the tumor, these patients tend to do much better than if we do radiation therapy alone. This is an FDA, this is a government-approved treatment for these cancers. What about the summary of current treatments for malignant gliomas? Well, if they're new, as you can see in this column, the type of tumor, as you can see in this column is the therapy. if you have a glioblastoma multiforme, which is a grade 4, this is the malignant cancer, we have maximal surgical resection plus radiation therapy plus concomitant and adjuvant temozolomide, or the wafers, the so-called gliadel. And I'll show you a picture of this right now. If it's an anaplastic astrocytoma, we also like to achieve a maximal surgical resection with options after surgery of standard treatment or radiation plus adjuvant use of temozolomide or temozolomide alone. These are slightly different protocols. What about an anaplastic oligodendroglioma, astrocytoma grade 3, where you can actually see maximal surgical resection with the options after surgery of radiotherapy alone, temozolomide, PCB, with or without radiation therapy? What about recurrent tumors? These ones are actually more complex in some cases, but also some of these treatments do exist for them, like reoperation in selected patients, and I show you an image that the reoperation is very, very important for these patients. At Johns Hopkins, we did a study a few years ago in which we look at radiation therapy with no gliadel, radiation therapy with gliadel, or radiation therapy with temozolomide. In a selected group of patients, we have used a combination of surgery with good resection, as you can see right here, with the intraoperative use of these little wafers that were invented by one of my colleagues at Johns Hopkins by the name of Henry Brem, that are called gliadel. We put them right at the time of the surgery, so the patient's already getting chemotherapy for the treatment. And then we give them an oral medication, which is the temozolomide. And in addition to that, the patients are also getting radiation. And it seems if we use a combination of good surgery followed by gliadel and temozolomide and radiation, these patients can survive up to 20 months. And as far as we know, in our experience, the number of complications, it's very, very minimal on these patients. I'll tell you something, and I'm going to wrap up in the next few minutes with the actual cell of origin of these differentiated glia or stem cell progenitors. There's been a fair amount of work in trying to understand how these tumors begin and how they continue. Well, this is a pathway from a low-grade oligodendroglioma going all the way up to an anaplastic oligodendroglioma, in which the median survival is 3 to 5 years. Alrighty? If it's a low-grade oligodendroglioma, the median survival is 5 to 10 years. But these tumors can actually progress from a low grade to a high grade. They're all in the spectrum of cancer. If you remember, we mentioned that earlier. So sometimes you can see a fair number of mutations. The one that I call to your attention is the P53, and as you can imagine, VEGF, vascular endothelial growth factor overexpression. A lot of these tumors have the markers for OLIG2 expression, which is thought to be, to some extent, the cell of origin, or one of the cells of origin for the progression, the origin and the progression of these tumors from low grade to high grade. What about the next type of tumor? The actual tumor that starts when the patient comes into the clinic is already a primary glioblastoma. The median survival for those patients, as you can see, is 12 to 15 months. This is a devastating disease. Once again, the most devastating cancer affecting the most beautiful organ in the body. One of the overexpressions is the epidermal growth factor receptor overexpression, over 60% of these patients. These patients are devastated. A lot of these tumors, they present like this. And the best way that I can tell you is a lot of my patients tell me that these tumors is like driving in the desert with your air conditioner on, and suddenly you get hit from the side and your whole life changes all of a sudden because of the diagnosis of one of these devastating tumors. But some patients can start with a low-grade astrocytoma in which the median survival is 5 to 10 years. It is in the spectrum of cancer. And then they can move on, if they recur, to an anaplastic astrocytoma, and then potentially to a secondary glioblastoma, which at that point, the median survival is much less. So that means they can start with a low-grade tumor and move all the way up to a high-grade tumor. As you can see, the median survival varies depending on where they start. And the higher the grade, the less chances they have of surviving for many years the disease. Our work at Johns Hopkins and at San Francisco, where I train, has to deal with whether or not there is an origin for these tumors and whether or not they are linked to parts of the ventricle, whether or not there's a cell of origin. In 2004, we published this paper. If you want to hear more about it, please tune in to my next segment of this series of talks. And we believe that potentially there's a series of cells that may be normal neural stem cells that can potentially give rise to these malignant tumors. That is still a working hypothesis. What we do know, and this is based around the same time in 2004, our colleagues from Italy and our colleagues from Canada published 2 different papers in 2 different journals with similar results. That is, if they get tissue from the patient and they grow them as small spheres and they put them back on animals, those tumors look very much like the tumor of the patient. Same thing with our colleagues from Canada. They did something similar, and what they find out is when they isolate using the marker CD133 and they put these cells back on the mice, they actually develop tumors that look like the parent tumor. So for the first time, alluding to the fact that there is potentially within brain tumors a small population of the so-called brain cancer stem cells, brain tumor stem cells that can actually give rise to the tumor. And those are the cells that no matter what we do, through radiation and chemotherapy and whatever we throw at them, they are probably surviving. And this is why these tumors are so devastating. This is a diagram based on a paper that I published a few years ago in which we look at not only neural stem cells, but also brain tumor stem cells and some of the similarities that they share. And this is why we've been so interested in trying to understand whether these neural stem cells can give rise to brain tumor stem cells. They have incredible migratory capabilities. They have regulation of pathways. As you can see, brain tumor stem cells, they have the ability of long-term propagation and dual phenotype labeling. So you have to be very, very careful in trying to understand these pathways and try to make sure that we carefully understand the difference between these 2 cell populations, because potentially we may be looking at a new way of treating brain cancer in the future. So let me tell you a few of the conclusions about brain cancer. It's been just little over 100 years ago since brain surgery for any type of disease, but specifically for brain tumors started. We are at the embryonic stages, in my opinion, of the development of new technology, new paradigms, new ways of looking at brain cancer. We have tumors that are considered to be non-cancerous and tumors that are considered to be cancerous. Within the cancerous family of tumors, we have the low versus the high-grade gliomas. We have the primary versus the secondary tumors. We have mutations that may potentially give rise to these tumors. For us, surgery is the first and most important step to control the disease in our patients. It's not a cure. The cure is only going to come from our future research. But within surgery, over the past 100 years, we've been able to perfect techniques to map the brain, techniques to be able to navigate the brain, and most important, we've been able to do surgeries on patients that are considered to be extremely technical in detail and extremely challenging, such as awake craniotomies. But this is not modern surgery. If you look back at the picture that I show you all the way back from Harvey Cushing, we are standing on the shoulders of giants. Brain tumor dispersal, which is the main challenge that we face, appears to have a population of cancer stem cells that give rise to these malignant brain tumors, and they share common characteristics. So our future challenge is going to be to understand this disease and the implications and hopefully develop new techniques. I thank you very much for your attention. If you want to learn more about brain tumor stem cells, that'll be our next segment. Thank you.